Well, thank you very much for both the very gentle introduction. I was kind of expecting you to be savaged in the introduction. It's most gracious of you. And thank you for the compliment of the invitation. It's always good. You know, people from Queens are a bit obnoxious and insufferable when they start talking about Queens.
We are.
I know.
It is the best place right here.
Right. I mean, I know that there are others who went to other universities, Mac, Western, McGill, Toronto, and so on. I guess some people prefer to be A students at B schools. I mean, what more can I say? I want to start off by saying that I believe in 2011, it is the responsibility of every clinician who sees smokers to be familiar with ways in which they can help patients stop smoking. That is, to initiate approaches to smoking cessation. It is no longer good enough for cardiologists or obstetricians or orthopedic surgeons or whomever to say, if they happen to pick it up, I see you're a smoker. In the weeks ahead, if you've got one, you might mention it to your family physician in order that somebody might do something about it. We don't do that if we identify dysglycemia. We don't do that if we identify hypertension or diminished renal function. Why on earth would we do that with what is Canada's leading cause of preventable disease, disability, and death? What I'm attempting to do today is to traverse these two valleys. We know that in terms of trying to influence clinical practice and professional behavior in the health community, we've got to move not only from the basic biomedical research and understanding to ensure that that's translated into the knowledge and appreciation of that knowledge that is part and parcel of a clinician's repertoire, but most importantly, the valley is deepest and arguably widest. We've got to make sure that that knowledge and that experience is now translated into what we deliver at the bedside. Because we can have all the academic knowledge about neurophysiology of this and neurophysiology of that, but unless it actually finds its way into helping our patients, irrespective of the area of clinical practice, then it's all for naught. It's been said, and this is very apropos today as it was a decade ago, it is difficult to identify any other condition that we encounter as clinicians that represents such a mixture of lethality, prevalence, and neglect, unfortunately, as does tobacco addiction, despite the fact that we have an array of effective and readily available interventions. So we know that smoking is by far the single most important modifier of pregnancy and pregnancy-related outcomes. We have been delinquent in terms of our inability to provide state-of-the-art evidence-based best practice interventions to our pregnant patients. We understand that COPD mortality is dramatically, distinctly, solely moderated or mediated by high rates of smoking. We know that irrespective of the state of somebody's respiratory health and the degree to which their lung function has declined, that it makes sense at any point to help those patients stop smoking. And all too often, the assumption on the part of clinicians is, oh, well, you're already on the oxygen tanks and you're 72 years old, why do I need to bother? We know that smoking cessation is most profoundly important in the management of cardiovascular disease. And in fact, one of the unfortunate realities is that there has been, until very recently, tremendous inertia on the part of cardiovascular specialists. We also make the assumptions that people who smoke a little don't have too much of a hazard. So you smoke 2 packs of cigarettes a day, your risk of a myocardial infarction is 800% that of a non-smoker. We get excited in the world of cardiovascular medicine with risk elevations of 40, 60, 70%. If you smoke 6 cigarettes a day, your risk of a myocardial infarction is still twice that of a non-smoker. But the good news is that particularly in the area of cardiovascular medicine, if we can help patients stop smoking, the benefits accrue far more rapidly than any other preventive intervention. And not only are these interventions effective and very powerful, they're also very cost effective. And that is that per life year saved through the treatment of smoking cessation costs about $2,000, $6,000. Life years saved through the treatment of hypertension costs up to $26,000. And cost per life year saved through the management of hyperlipidemia can approximate or approach almost $200,000. Now, that is not to say these are unimportant or overtly expensive. These meet all the criteria as being cost-effective, cost-efficient kinds of interventions. But it puts into perspective the power and the efficiency of this particular intervention, particularly when you recognize that if you help somebody stop smoking, you eliminate a risk factor. So Many of you have heard me describe this young lady before, so I'll try to be mercifully quick. This is a young lady I met at 3 o'clock in the morning on an elevator in our campus. She's in her early 30s. She's very articulate. It turns out she's a young member of Canada's Foreign Service. She's wearing a high-fashion, pale blue, thin Ottawa hospital gown, nothing else. She's attached to and is pushing her IV pole. I'm heading outside. We all know why she is heading outside. That particular morning in January, the temperature was minus 24 Celsius. This slide tells us two things. That at this particular hospital, I am sad to say, substandard care is still the norm. And I want to very seriously, in a very blatant, overt way, say that if we have patients going out the front door, the side door, the back door, smoking, in 2011, we are providing substandard care. Whether you are admitted to hospital in premature labor, with a compound fracture of your humerus or an anterior wall infarction, if you're a smoker, very predictably you will go into nicotine withdrawal in the first few hours of your admission. And for many people, that translates into obnoxious, aggressive, uncooperative, boisterous behavior. This is a very tenacious addiction. And if you examine those substances in our community which are likely to induce addiction, you see that the probability of dependence after being exposed to a substance at least once is highest for tobacco or nicotine than for any of these other substances. And I would ask you to commit, never ever again, in any sentence in which the word smoking appears, to use words like habit, behavioral choice, lifestyle choice. Because to do so immediately reveals you don't understand the fundamental mechanisms which initiate and perpetuate smoking behavior, the most sophisticated drug delivery device in our community. And we assume that this is just a hollow paper tube filled with some leaves stuck to something we laughingly call a filter, and people light it and, they got this habit, right? Hundreds of millions of dollars are spent each year perfecting the design of this device. And so most clinicians would be blissfully unaware of concepts like front-end lift, a design precept known to every cigarette design engineer. You manufacture a cigarette such that the first millimeter or two of that tobacco is denser in its nicotine content. And so that when an individual lights that cigarette and inhales, they have one of these moments as they get a big hit of nicotine and replace the growing discomfort of withdrawal with what is perceived as the pleasure of nicotine replacement. There's no such thing as a light cigarette. All smokers, with exquisite precision, titrate their nicotine intake. And so an individual who smokes a light cigarette, which is manufactured by packing the tobacco leaf more loosely in this paper tube, and then drilling with lasers perforations in the filter tube area, smokes those cigarettes very differently. And the whole idea of doing this, by the way, is so the tobacco industry can put this device on a vacuum tube, apply a low level of vacuum, more air swirls around the loosely packed tobacco, huge volumes of air come in through what the industry themselves describe as the ventilation holes. And per unit volume of smoke, the smoke is more diluted. And so the industry could, until they were prohibited from doing this, except in the United States, say low tar, low nicotine. And the consumer deludes themselves into thinking that somehow their smoking is safe for cigarette. There are a number of factors which determine whether or not somebody is likely to become a smoker or likely to be able to quit smoking with relative ease. And there are gradations in the degree with which one can stop smoking. And we know that principal among those factors is the rate at which you metabolize nicotine. If you're a fast nicotine metabolizer, you're very likely, with minimal exposure to smoking, to become a smoker. Some of you, at university, college, high school, whatever, may have attempted, for whatever reasons, guilty as charged, Your Honor, to try to become a smoker because it was the cool thing to do, the guys in the football team were doing it, or whatever. And you just couldn't ever seem to somehow become a smoker. And I guarantee you, you are a slow metabolizer of nicotine. Fact one, the overwhelming majority of your patients know why they shouldn't smoke. Fact two, a substantial majority of your patients who smoke do not want to be smokers. In fact, three, a majority will make at least one or two personal, private, quit attempts each year, 95% of which will fail. And so patients don't require information or lectures. They want help. They want assistance. This slide just makes the point that I probably made tiresomely a few moments ago, that all smokers smoke to maintain a certain level of nicotine, represented by this broad band. The jagged green line represents rising and falling levels of nicotine in association with a cigarette. These are venous levels of nicotine. If we were to look at arterial levels of nicotine associated with smoking a cigarette, they'd be on the ceiling 1 or 2 floors above. This represents the level of nicotine produced by standard doses of nicotine replacement therapy. So all smokers smoke to maintain a certain constant level of nicotine intake. We also know that today, when by and large those for whom cessation is easier have quit smoking, that those of our patients who remain smokers are particularly in need of, and I would argue deserving of, much better and much more effective assistance. And it's also important for us to understand that the only group in our community that has never discriminated against the mentally ill is the tobacco industry. And indeed, there are distinct documents that show that the tobacco industry identified psychiatric populations as potential targets for their particular products. We know that 44% of all cigarettes consumed in North America are consumed by individuals with psychiatric comorbidities. We know that, unbelievably, the life expectancy of psychiatric patients in Canada who are smokers, or psychiatric patients, pardon me, is 25 years less than that of other Canadians. A huge proportion of that discrepancy is accounted for by tobacco-related diseases. And our psychiatric colleagues are becoming much more familiar with the fact that now their patients don't die of mental illness or the consequences of their psychiatric illnesses. Instead, they die as a result of tobacco diseases. And so there are some opportunities to do some very novel and innovative things in this particular area of practice. Well, why might that reality be so? On the left, general population, 18% smokers. On the right, depressed population, or those with a history of depression, the majority are smokers. This might provide some insight. Something is lighting up the scans of the non-smokers in the kidneys, the liver, the heart, and the brain that is absent in the smokers. And that something is monoamine oxidase. And once again, most clinicians are blissfully unaware that hundreds of times a day, smokers are self-administering small doses of monoamine oxidase inhibitors, which are antidepressant medications. And so many individuals who have a history of depression feel better when they're smoking. And conversely, those who stop smoking may sometimes begin to experience symptoms of depression as they have been unwittingly self-medicating, often for years, not recognizing the benefits that accrue to them as a result of their smoking. We know that schizophrenics have prodigiously high rates of smoking. And schizophrenics derive relief from their symptoms because nicotine, in their case, stimulates something we call the alpha-7 nicotine receptor, which has the effect of blunting, reducing, quieting the multiplicity of auditory, visual stimuli that constantly assail and bombard a schizophrenic, so that those individuals feel somewhat better while they are smoking. But paradoxically, other products in tobacco smoke accelerate the metabolism of antipsychotic medications, just as they accelerate the metabolism of respiratory medications, cardiac medications, some antibiotics, etc., etc. Again, relationships about which most clinicians are completely unaware. Why would we bother learning about this? This is, after all, just a habit. And we all know that everybody should be able to stop smoking if they were just better people. Are you listening to me? How long have you been in the practice, right? So we should be addressing smoking in exactly the same way that we address hypertension, hyperlipidemia, diminished renal function. We don't say to our hypertensive patients, gee, I see your blood pressure's been elevated on 3 or 4 occasions. Why don't you go away if you think about it, and if you've got one, speak to your family physician about undertaking a hypertension control attempt, right? We don't do that. And we haven't established huge kinds of constructs which say, I want you to go home now and think very seriously about the factors which might influence your willingness to undertake a hypertension control attempt in the weeks ahead.